Welcome to the Medical Gas Mandatory Training video. During the course of this video, we will cover 6 main topics. These include introduction to medical gases, identification of medical gas cylinders, safe handling of medical gas cylinders, medical gas cylinder valves, medical gas hazards, patient safety alerts, prescribing and administering oxygen. Medical gases are classed as a drug and should be prescribed. The only exception to this is oxygen in an emergency situation, such as a cardiac arrest. This should still be entered into the patient's records after the event. Medical gases can be classified into 3 states. Permanent gases. These are gases that remain in the gaseous state in the cylinders at normal temperatures. The volume of the contents of the cylinder is directly related to the pressure of the gas. For example, at a quarter of the filled pressure, the cylinder is a quarter full. Such gases include oxygen and medical air. Liquefiable. These are gases that are supplied as a liquid at normal temperatures. For example, nitrous oxide and carbon dioxide. Cryogenic. Gases supplied as a liquid at a cryogenic temperature, that is, below -40 degrees Celsius. For example, liquid nitrogen and liquid oxygen. The content of the medical gas is identified on the shoulder of the cylinder. Oxygen may be piped or in a cylinder. The shoulder of the cylinder is white. Medical air is black and white, which tends to be used for the delivery of nebulizer medications. Entonox. It's blue and white and can be used for short-term pain relief. Nitrous oxide is a combination of nitrogen and oxygen. The shoulder of the cylinder is all blue, and this tends to be used mainly in anaesthesia. Carbon dioxide has a grey shoulder and is used to treat respiratory disorders and surgical dilation. Heliox. Brown and white and can be used to treat some respiratory disorders. Helium. All brown shoulder and can be used in aortic balloon pump therapy. Additional information is provided on the cylinder collar label. This includes the expiry date. This should be checked on a monthly basis by the ward team and escalated to the estates team if needed replacing. Gases are supplied through 2 mechanisms: gas pipeline systems or medical gas cylinders. Where possible, pipeline systems should be used over cylinders. Piped gases are supplied from large holding tanks on the hospital site. The use of this is monitored centrally by the estates team. If there is a piped cylinder failure, compressed gas cylinders can be used. You should familiarise yourself with the medical gas alarm system within your clinical area linked to the piped gases. Locked boxes containing isolated valves in enclosures with breakable glass fronts are called Area Valve Service Units, or AVSUs. These are provided at the entrance to wards and departments that have access to piped gases. You need to be aware of where the Area Valve Service Unit, or AVSU, is for your clinical area. This is used to isolate medical gas supplied within your area in the case of an emergency. All AVSUs have a unique number and tag system for identification. These valves provide facilities for both routine and emergency isolation of gas supplies. These valve boxes contain an emergency inlet port, which is gas-specific. This may be used to supply gas to a ward when the main supply fails or is shut down for essential engineering work. In the event of an emergency, access to the valve boxes and AVSUs may be gained by smashing the breakable glass fronts. A member of the nursing staff, usually the senior sister in charge of the ward that day, will perform this action after steps have been taken to ensure that no patient is compromised by the isolation of the gas supply. Compressed gas cylinders are a convenient way of delivering medical gases when piped gases are not available, for example, during patient transport. Each cylinder is given a letter code depending on the size, construction and valve type. Each ward has a designated cylinder area. If this is not the case, it should be escalated to your ward manager or matron. The quantities of the medical gas cylinders stored on wards should be kept to a minimum amount required for that clinical area. The quantities held should be checked daily. Ideally, not more than 24 hours worth should be stored in a clinical area. The designated area should be clutter-free and away from all combustible materials and labelled with the appropriate warning signs. Before handling a medical gas cylinder, ensure your hands are clean. Do not use oil-based hand creams and ensure alcohol gels have evaporated so your hands are completely dry when handling a cylinder. You must check the cylinder conditions to ensure there is no sign of any damage. The cylinder is free from oil or grease. You must contact the estates team if you have any concerns. Ensure that you have the correct medical gas by checking the cylinder label and check that the cylinder is in date. This is on the square batch label on the cylinder guard or collar. Check the cylinder gauge. If unused, the needle should be in the green zone, indicating that the cylinder is full. If the cylinder has been used before, check the needle to see how much gas is available. Ensure you have enough to treat your patient. If the needle is in the red zone, this indicates that the contents are low and you should consider replacing the cylinder before treating the patient. If the cylinder is new, remove the tamper-evident hand wheel by pulling the tear ring. Remove the valve outlet cover. Ensure the flow selector on the top of the cylinder is set to 0 and the hand wheel is turned off before connecting equipment. Cylinders can be described as either faulty or incident cylinders. A faulty cylinder is minor, where a patient is not at risk, but the incident should be still documented using the Trust Incident Monitoring System. For example, an empty cylinder stored and therefore not working when required or a minor leak. An incident cylinder is a greater risk, where there has been contamination of the medical gas. Labelling has been removed, damaged cylinder, or an abnormal reaction causing harm to the patient. This should be quarantined and both pharmacy and estate should be informed to contact the gas supplier. There are 4 basic valve types: bullnose, hand wheel, star, and pin index. Bullnose valves are used on larger cylinders. Gas connection is made between the spherical end, or the bullnose, of the regulator and the seal of the valve outlet. The hand wheel valve is used on F, G, and J sizes of medical nitrous oxide, VF and LF sizes of carbon dioxide, and many pathology and industrial gas cylinders. A flat sealing washer fits between the cylinder connector and valve. The cylinder is usually provided with a metal valve protection guard, and the gas outlet is fitted with a plastic or metal blanking cap. Plastic caps should be discarded before use, but metal screw-on valve covers should be retained and replaced before the empty cylinder is returned to the supplier. If fitted, the valve guard should not be removed. The star valve combines a regulator and valve as a single unit. They are operated by a single hand wheel and are fitted with a variety of outlets. A range of output flow rates is also available. They are fitted to some sizes of medical air and oxygen cylinders. Pin index valves with a top spindle or knurled knob are fitted to all E-size and smaller cylinders, as well as to F and G-size Entonox cylinders. Pin index valves with a side spindle, J-size oxygen, and medical air for manifolds should be operated with the correct key. Safety notes. A. The pin index valve is not fitted to a G-size medical air and oxygen cylinder, and it is still possible to interchange these gases in ward areas where G-size cylinders attached to items of medical equipment are in use. B. Knurled knob valves are fitted to smaller size of nitrous oxide cylinders should not be used to carry the cylinder, as it is possible for the valve to be opened accidentally, resulting in discharge of high pressure expanding and hence cooling gas into the hand. Frostbite could result. C. While the colour codes are being revised, care must be taken to ensure that the new cylinders of industrial oxygen at a pressure of 230 bar and having a black cylinder body and a white shoulder akin to the old style medical oxygen cylinder colour code. Suction should be applied with care. Suction units may be situated near medical gas units. You should ensure that you have been trained to use suction by a competent member of staff if you have not used this before. Medical gas hazards, oxygen enrichment and oxidization. Causes can result from leaks from poor connections or damaged cylinders or equipment. This can include excessive flow rates, leaving the medical gas on when it's no longer needed, or poor ventilation. An increase in only 4% concentration doubles the risk of ignition from spark or electrical equipment, leading to combustion. Vulnerable materials such as hair, clothing, linen, dressings, cardboard, paper, cleaning agents, hand gel, and electronic equipment. Avoidance of combustion is ensuring correct flow of the medical gas and ensuring medical gases are stored appropriately away from combustible materials. It must be ensured before use that both flow meter or cylinder is not damaged and in date, the correct flow rate is used, and that all medical gases are switched off if not in use. When setting up a medical gas, ensure hands are clean and free from grease, alcohol gel, hand creams. Avoid placing any gas cylinders on the bed with a patient. Pressure on its own is not dangerous. The pressure within the gas cylinder can be 300 times that of a car tyre. Cryogenic gases are stored up to minus 180 degrees Celsius, and prolonged use can cause severe frostbite. The staff member must ensure that they have been trained and feel competent to handle cryogenic gases before using. Please refer to someone who is competent for training if you have not handled these gases before. If decanting cryogenic gases, the full PPE must be worn. This includes protective visor, gloves, and an apron. Asphyxiation occurs when the environment has become oxygen deficient, below 20%. This can be due to the use of nitrogen, nitrous oxide, carbon dioxide, or helium. Above 18%, there are very limited symptoms demonstrated. Between 11 and 18%, a reduction in mental and physical performance, although this may not be apparent to the individual affected. Between 8 and 11%, fainting may occur, leading to a coma or potential fatality if not resuscitated immediately. Anything below 6% is extremely difficult to recover from. National Patient Safety Alerts. There are 2 medical gas alerts specifically related to the use of oxygen. The first alert highlights the importance of checking that oxygen tubing has been connected to the correct oxygen flow meter and to ensure that established systems are in place to reduce the risk of connecting the oxygen tubing to an air flow meter. The accidental administration of air instead of oxygen to a patient is a never event. This can cause severe harm or even death. The recommendations of the National Safety Alert are aimed to decrease human error, but continuous vigilance is required. There are 3 recommendations from the National Patient Safety Agency that must be actioned. Medical air terminal units, wall outlets, are covered with designated caps in areas where there is no need for medical air. Medical airflow meters are removed from terminal units or wall outlets and stored in an allocated place when not in active use. Airflow meters are fitted with a labelled movable flap. In an emergency, airflow meters are never required, therefore the lack of access to them does not introduce or increase risk to patients. The second alert refers to the safe administration of oxygen via portable cylinders when there is no access to the piped medical gas supply. There have been several reported incidents, as listed here, related to the inability of administering oxygen via a cylinder due to a variety of errors which have led to serious deterioration and even cardiorespiratory arrest of patients. It is crucial that all staff who manage, operate, and administer medical gas cylinders are trained on the safe use of these. Always ensure that the oxygen is being delivered at the point of connecting the supply to the patient and perform regular checks throughout the duration of administration. Ensure that the cylinder has adequate amounts to maintain supply for the patient's requirements. Always administer the correct amount needed. Cylinders must be stored, handled, and transported correctly to avoid the risk of fire and physical harm. Please watch this video, which demonstrates the principles of safe operation of oxygen cylinders.
Before handling cylinders, ensure your hands are clean. If you have been using alcohol-based gel or liquids to decontaminate your hands, make sure the alcohol has totally evaporated. When selecting the cylinder for use, check the cylinder is clean and free from any damage. Ensure the cylinder is free from oil and grease, particularly around the Schrader and fir tree outlets. Ensure you have the correct medical gas by checking the cylinder label. Check the expiry date on the batch label fitted to the cylinder. Make sure the contents gauge is in the green zone. This indicates that the cylinder is full. Remove the tamper-evident handwheel cover by pulling the tear ring and discard into a recycle bin. If the cylinder has been used before, this cover will not be present. Ensure you have sufficient gas for the treatment by inspecting the contents gauge. If the needle is in the red zone, there is a limited capacity and you may need to change the cylinder. Prepare the cylinder for use before placing near the patient. Do not place the cylinder on the bed with the patient. A suitable holder should be used where possible. Remove the valve outlet cover. The hinged grey cover is pulled down. Do not remove the grey cover, as you can refit after use. Ensure the flow selector on top of the cylinder is set to 0 and the hand wheel is turned off before connecting the equipment. Attach tubing from mask or nasal cannula to the Furtry outlet securely. Slowly turn on the cylinder by rotating the hand wheel anti-clockwise until it comes to a complete stop. Set the prescribed flow by rotating the dial flow selector. Ensure that the correct flow rate number is clearly visible in the flow selector window. Check the gas is flowing. Ensure the cylinder is turned on and leak tested before placing near a patient. Use a suitable cylinder holder where possible. Insert the oxygen probe into the Schrader outlet. Ensure the probe clicks securely into place. Slowly turn on the cylinder by rotating the hand wheel anti-clockwise until it comes to a stop. Check for leaks, which may be indicated by a hissing sound. Place a mask or nasal cannula onto the patient. If using a mask, ensure a tight seal. Ensure the clinical condition of the patient remains satisfactory throughout the therapy. Use pulse oximetry where appropriate. Check the contents gauge at regular intervals to ensure there is sufficient gas. Remove the mask or nasal cannula from the patient. Turn off the cylinder by rotating the hand wheel clockwise until it comes to a stop. Remove the tubing by firmly pulling the tube whilst holding the cylinder handle. Release the probe by twisting the capstan clockwise or by pressing the outer circle of a quick connector. Turn the flow selector to 0. Replace the outlet cover. Pull up the hinged grey cover. Check the cylinder gauge for content level. Return the cylinder to a designated in-use or empty storage area.
It is crucial that all staff dealing with oxygen cylinders are trained for their safe operation. Always check the correct medical gas is in use, checking the label, the expiry date and the batch label. Check that there is enough oxygen available in the cylinder for the task required. Remove the tamper-evident hand wheel covers. Turn the black valve to the open position. Connect the oxygen tubing for the appropriate mask for the patient. That is, a high concentration, non-rebreathable mask needs a flow rate of 15 litres per minute. Make sure that the bag fills and the full cylinder size CD will last 30 minutes. A nebulizer mask at a flow rate of 8 litres per minute will last around 55 minutes, and in an emergency, a bag valve mask at a flow rate of 15 litres per minute will last 30 minutes. Always have a spare full oxygen cylinder ready when using the high flow rates. The oxygen cylinder duration chart provides a guide on how long a cylinder supply can be maintained for, depending on the size, their contents, and the flow to be used. This chart should be displayed in all clinical areas adjacent to where the cylinders are stored. Please ensure that staff can safely operate oxygen cylinders. When checking the storage of oxygen cylinders on the ward, please return empty cylinders and ensure they are replaced immediately. Please also return any surplus stock. Always check the expiry date on the cylinders prior to use, with routine daily checks to be performed on emergency use cylinders, for example, resuscitation and transfer trolleys. There have been a number of patient safety incidences related to the inappropriate use of oxygen. These have been reviewed and the appropriate action must be implemented as guided by lessons learned. Administration of air via an air flow meter was discontinued in 2019. If air is administered in error instead of supplemental oxygen, this is now classified as a never event. Blocking caps are now inserted into the piped medical air outlets to minimise this risk relating to human error. If there is a clinical need to use the piped air via flow meter, this must be removed from the outlet after use and stored away and the blocking cap to be reinserted. Safe handling of oxygen training must include guidance on how to operate, check and confirm the correct output of oxygen from the cylinder. One serious incident included the unsafe transfer of a critically ill patient, where the safety valve of the oxygen had not been correctly switched on, resulting in the patient dying. Always check and confirm there is oxygen flowing through the mask before applying to the patient. Also, ensure there is enough oxygen supply in the cylinder for the full transfer duration, taking into account the distance to travel and any potential delays. Please refer to the oxygen cylinder duration chart, and if in doubt, please ask for help. A further incident occurred where staff had not opened the pull cap of the oxygen cylinder and an acutely ill patient failed to receive oxygen therapy. Please always ensure you are familiar with the correct operation of the cylinders and check and confirm that there is oxygen flowing before applying to the patient. Finally, an incident occurred in 2021 relating to an oxygen tank where the dial was not open. Staff are less familiar with this type of equipment. Please always ask for help if you are unsure how to operate the device you are using or how to perform the necessary safety checks. Always ensure and confirm that oxygen is flowing before applying to the patient via an interface. Prescribing and administering supplemental oxygen. Oxygen administration must be prescribed at all times on retrospective paper or electronic chart, with the only exception being in the case of an emergency, such as a cardiac arrest or a peri-arrest situation. When prescribing oxygen, please define the device used, if requiring humidification or not, and always make sure that there is a target oxygen saturation with the range. For example, 88 to 92, or 90 to 94, or 94 to 98%. Ensure that the use of oxygen is also documented on the retrospective paper or electronic clinical observation chart. In case of an emergency, such as a cardiac arrest or peri-arrest situation, please call for help and administer 15 litres per minute of oxygen via a non-rebreathe face mask or ambibag. The need for oxygen therapy will vary in different patients and in different circumstances. This algorithm describes the safe and effective use of oxygen therapy in the acute setting, simplifying the targets into two groups: those at risk of developing hypercapnic respiratory failure, even if not currently hypercapnic, or already developed respiratory failure. The algorithm provides recommendations on the initiation of oxygen therapy and how to monitor the patient and required frequency of observations thereafter. Oxygen helps patients to achieve target saturations. However, it is very important to address any underlying causes as part of the safe management of the hypoxic patient. For example, antibiotics for chest infection and chest physiotherapy to manage consolidation and sputum plugs. If a patient's oxygen requirements continue to escalate and the patient needs more than 50% oxygen to maintain target saturations for more than 4 hours, please seek urgent help. Ensure the patient has been reviewed on the ward by a senior clinician, that an escalation plan has been agreed, and if appropriate, consider referral to critical care outreach team. Always remember, supplemental oxygen administration is considered a drug, and therefore it must be prescribed. Prescription of this must include a target saturation range with a specified device, and if humidification is required on the respective paper or electronic prescription chart. High-flow oxygen prescription charts or non-invasive respiratory support charts. Patients' oxygen requirements and device should also be documented on the clinical observation chart. The administration of supplemental oxygen can be done with different devices. The amount of oxygen delivered should ideally, if it is able to be measured, be documented as a fraction of oxygen percentage, known as FiO2. For example, via the Airvo, or with the Venturi device that has a fixed FiO2. Please document number of litres per minute of oxygen given and the device used. If oxygen requirements keep increasing to be able to achieve the prescribed target oxygen saturation, please escalate and ensure the patient is reviewed and the cause is addressed. If more than 50% oxygen is required, ensure that the patient escalation plan is reviewed and if appropriate, refer to critical care outreach team. This is the currently used paper oxygen prescription chart. Please ensure that any changes on the amount or form of oxygen prescription is documented, including the reasons for changes. This is the current paper form used to prescribe high-flow oxygen therapy. Please ensure oxygen saturation targets are documented alongside any changes in therapy. The critical care outreach team will initiate and follow up any patients on high-flow oxygen therapy. This is the current paper form used to prescribe non-invasive respiratory support, BiPAP or CPAP. Please ensure oxygen saturation targets are documented alongside any changes in therapy. Patients on acute non-invasive respiratory support should be managed on the acute admission or respiratory support units or within the critical care areas. Here you can see examples of how supplemental oxygen therapy is monitored and documented on the paper or electronic clinical observation chart. The NEWS 2 scale, 1 or 2, must be used according to patient condition. Oxygen prescription is regularly audited with set standards of 100%. Oxygen prescription is regularly audited with set standards of 100% prescription of oxygen therapy, and 100% target saturations range are documented. Audit results and patient safety instances have demonstrated there is still room for improvement and the need to continuously monitor compliance to promote safe and effective administration of oxygen therapy. In 2022, an incident occurred due to a lack of documentation. Following a ward transfer, a patient receiving supplemental oxygen therapy was due to be weaned. This was handed over but was not written down or prescribed. This resulted in delayed reduction of care and extended hospital stay. In 2023, a serious incident occurred due to the lack of oxygen prescription, also when a patient was transferred from one ward to another. They had required supplemental oxygen therapy on the base ward and were transferred to another ward, but without oxygen in situ. This was not recommenced on receipt to the new ward until a new set of observations demonstrated that the patient's oxygen saturations were low. Always ensure that oxygen therapy requirements are included in any handover of care from team to team. Safe use of oxygen requires effective communication, documentation, and prescription to help keep patients safe. Thank you for taking the time to watch this video.